and canal stenosis. اوكي طيب بدنا نعرف اول شيء what is the anatomy of the disc itself. Okay, the intervertebral disc. Each intervertebral disc is composed of two main components, which is the annulus fibrosus and the nucleus pulposus. The annulus, which is the outer concentric fibrocartilaginous and fibrous connective tissue material, which is composed mainly from collagen type 1, which is like the bone. Bone is B1. أسهل طريقة تحفظ فيها إنه الكولاجين type 1. تمام. Annulus is also type 1 collagen. The nucleus pulposus is type 2 collagen. Mostly component تبعتها 85 to 90% water content. تمام. فنشوف الصورة هنا في عنا this is simplifying the intervertebral disc anatomy and its relation to the nerve roots and the canal. Okay. ففي عنا هنا كلنا شايفين this is the outer part, which is a concentric fibrous fibrocartilaginous tissue made of collagen type 1 اللي بنسميها الannulus fibrosus, and this is the inner concentric part which is the nucleus pulposus, which is to the inside. فشو هو الفانكشن تبع الانترفيرتبرال ديسك؟ الانترفيرتبرال ديسك it acts as a cushion between the two vertebrae. Okay. طيب the disc herniation or protrusion is a bulging of the disc with the outer part of the annulus intact. أول شيء نعرف إيش يعني protrusion. Protrusion يعني إنه the nucleus pulposus just bulged, it herniates. زيها زي أي نوع من أنواع الهرنياز أخذناها قبل هيك بالجراحة العامة أو بأي اختصاص زي الانجوانال هيرنيا زي الفيمورال هيرنيا. It's a protrusion of viscus. هون عندنا protrusion of the nucleus pulposus through the annulus. Okay. هلا الannulus if it ruptures the disc material it will sequestrate to the outside and it will lie free in the spinal canal or the intervertebral foramen. The classification of herniation زي ما حكينا protrusion الannulus it remained intact but the nucleus pulposus it bulged through the annulus, أو ممكن يكون عندنا extrusion إنه صار في عندنا tear بالannulus fibrosus and the nucleus it protruded to the outside but it remained connected with the central part of the nucleus. Okay. Or it can be sequestrated. Sequestrated, it means that part of the nucleus pulposus have been separated from its central part and remained inside free in the canal. Okay. زي في عندنا هاي الصورة أول واحدة اللي هي example of protrusion. في عندنا هون this is the nucleus. It protruded to the outside and caused this bulge. Okay. This is the most simple part, the simple issue. اللي هو main cause تبعه increase in the intradiscal pressure. بيزيد البريشر inside the intervertebral disc that will cause the nucleus to bulge. Okay. The other example which is ايش؟ حكينا extrusion. The extrusion that there is a tear in the annulus fibrosus. Okay. And the intervertebral disc it became separated. It became herniated to the outside, but still remaining in continuity. Okay. This is what we call extrusion. The sequestration, here we have the intervertebral disc material have been separated away from the nucleus. طبعا عندنا أول شيء اللي هو أبسط واحد هو protrusion. الannulus is still intact. It may cause only increase the intradiscal pressure. Type 2 اللي هو extrusion or sequestration. You must have an annular tear. Annular tear in the annulus fibrosus طبعا إحنا قصدناه. Okay. هلا بدنا نعرف شغلة بسيطة اللي هي بدنا نسيت شو كنت أحكي. أوكي. طيب نكمل النكست سلايد. نعرف إنه باللمبر spine the most common site which is L4, L5 and L5S1. The cervical spine the most common site is C5, C6 and C6, C7. Okay. The disc where it will herniate. The direction mostly is posterior. ليش ما بصير في عنا anterior disc herniation؟ ليش disc herniation always toward the posterior? Actually, we can have anterior disc herniation, but the first thing, the anterior longitudinal ligament is very strong, so most of the disc herniation will go posterior rather than anterior. Next thing, the anterior disc herniation, they don't have a clinical importance because there's no vital structures to be compressed from the anterior vertebral part. أهم شيء عندنا دائما posterior disc herniation. Already the anterior longitudinal ligament is stronger than the PLL اللي هو posterior longitudinal ligament. فالدايركشن حيكون عندنا either posterior أو posterolateral أو lateral disc herniation. هاي الصورة مهمة كثير نعرف ونفهم عليها example معين انه when we have a disc herniation which nerve root will become compressed. نعطي هذا الاكزامبل. let's assume this is a lumbar disc region. نعتبر انه this is L4 and this is L5. مهم كثير نعرف انه النيرف روت اللي هو pass under the corresponding pedicle of the vertebra. So this is L4 nerve root and this is L5 nerve root. Okay? فلما يكون في عندنا L4 L5 disc herniation posterior or posterolateral, like in this example, the nerve root that will be compressed is L5. The rule is simple. Anywhere in the vertebral column, when you have disc herniation, the nerve root that will be compressed is the lower part. يعني إذا عندي L2 L3 اللي حيكون له compression L3. إذا عندي C4 C5 راح يصير النيرف روت اللي حيصير له compression اللي هو C5. Whatever حتى لو كان thoracic even they are rare. لو كان عندي T10 T11 النيرف root that will be compressed اللي هو T11 اللي هو اللور part اللي هو حيكون في نيرف روت حيكون له في compression. الاكسبشن عندي بكل السباين اللي هو اللمبر region when you have a far lateral disc herniation. نفس الاكزامبل هون this is L4 L5. Here we have a far lateral disc herniation. Okay? That's what we call lateral or far lateral or foraminal. يعني ممكن الاسم يكون بهذا الشكل. Lateral disc herniation, far lateral or even foraminal disc herniation. اللي بيكون عندي nerve root that will be compressed here is L4. Okay? The exception باللمبر spine because the nerve roots they go vertical and then go under the corresponding pedicle. بباقي spine, all of the nerve roots they will go directly through a horizontal route under the pedicle. The exception الوحيد عندي هنا باللمبر spine you go vertical and then under the corresponding pedicle. طيب دائما نعرف اللي هي الcommon dermatomes and myotomes that they will be compressed. The cervical spine most common site is C5 C6 and C6 C7. فusually لازم نحفظ ال C4 و C5 و C6 و C7 motor and sensory and reflexes corresponding to this nerve root. In the lumbar spine the most commonly involved اللي هم L3 L4 L5 and S1. فلازم كلنا نعرف ال dermatomes and the myotomes that they are involved and the reflexes. نعطي فرضا for example في عندي هنا L4 و L5 إذا شايفين على الجدول بالlower part اللي مثلا بيعطي dermatomal pain على middle aspect of the calf in L4. muscle supply tibialis anterior and the quadriceps عندي مثلا L4 it assists in extension of the knee and also in dorsiflexion of the ankle. Okay? Movement weakness to extension, ankle dorsiflexion and also foot inversion and the knee extension and also in ankle dorsiflexion. فلازم نعرف السنسوري والموتور dermatomes and myotomes ولازم نعرف عندي reflexes corresponding to those nerve roots. The causes of having intervertebral disc, there is no direct cause. There is a lot of risk factors. One of them, repetitive mechanical activities related to work, mostly. Sedentary lifestyle, having weak muscles and having sedentary lifestyle increasing your risk to have disc herniation. Acute disc herniation related to traumatic injury, one of the causes. Obesity, it increases the risk because it increases the intradiscal pressure. Practicing poor posture also increases the intradiscal pressure and with variation of the distribution of your weight and gravity upon the intervertebral disc. And also tobacco use because of repeated coughing. Because of repeated coughing, that will cause also increase the intradiscal pressure. The cervical disc prolapse, the pathophysiology and all of the details are the same. In many cases, there is a predisposing abnormalities of the disc with increase in nuclear tension اللي هو حكينا ممكن يكون عندي زيادة بالintranuclear pressure. The original attack can sometimes be related to a specific strain episode like acute flexion of the neck during intense physical exertion or occasionally sometimes related to a whiplash اللي هو مرات we refer this term as an acute disc herniation. The clinical features, pain and stiffness in the neck that often radiates to the scapular region, pain and paresthesia in one upper limb often radiating to the outer elbow, back of the wrist and the index. Weakness is rare usually in cervical acute disc herniation. Okay? Patients usually will take a certain position of their cervical spine to avoid irritation to the nerve root with a certain tilt forward or sideways according to the level of the lesion. بدنا نعرف بس فرق صغير انه انا عندي lumbar spine, the spinal cord will end between L1 and L2. So most of the disc herniation in the lumbar spine, they will cause radiculopathy, which is compression over the nerve root. In the cervical spine, we can have radiculopathy with pain radiating from the neck to the arm or the forearm or even to the wrist, or we can have myelopathic pain. Myelopathic pain, it means that the disc is compressing the spinal cord itself. احنا عندنا باللمبر spine, spinal cord it terminated at almost at the level of L1. In the cervical spine, it's different that we still having the spinal cord and having the nerve root. So the presentation of the cervical spine can vary between radiculopathic pain or myelopathic symptoms, which is referring to upper motor neuron lesion. In the lumbar spine, the symptoms is mostly radiculopathy, or ممكن يكون في عندنا terminology اللي هو اسمه كونس ميدالاريس syndrome أو كودا إكواينا syndrome. الكودا إكواينا أخذناها بالpartial cord lesions اللي بيكون في عندنا weakness in the lower limbs، بيكون عندنا bilateral weakness in the lower limbs، بيكون عندنا saddle paresthesia. Saddle paresthesia, it means in the area of the perineal part, in addition to loss of sphincter and loss of sphincter control regarding bowel and urinary function, and also sexual dysfunction. هذا كلاتهم constellation of symptoms, we call it اللي هي كودا إكوانا syndrome. Diagnosis of intravertebral disc herniation, we're starting with the X-ray. X-ray, because of the pain, patient will attain certain position to decrease the pain. That's why most of the patients, they will have straightening and loss of normal lordosis in the cervical or in the lumbar spine. عشان هيك the straightening of the cervical spine or the lumbar spine is most likely positional and is not related to muscle spasm as most of physicians will refer, but most likely this is a protective mechanism to get this position to decrease the pain and to decrease the irritation of the nerve root. Okay. Next step, CT scan is not helpful most of the time because CT will demonstrate bony shape rather than the soft tissue and the nerve roots and the disc itself. MRI is the most helpful method for diagnosis. Another alternative method sometimes that we do it, which is CT myelograph. CT myelograph is the most accurate, but it's not used routinely because you have to inject a dye inside the intrathecal space. Okay? When we do CT myelogram is performed mostly when MRI is contraindicated. امتى MRI بتكون contraindicated? Usually with patients who have battery devices implanted inside their body, زي defibrillator, زي vagal stem stimulator, زي deep brain stem stimulators, زي في اللي بيكون محطوط لهم pacemakers أو defibrillators حكينا بالهارت. Any device that contains battery, most of the time MRI is contraindicated. The most common cause of having MRI being contraindicated اللي هي patients anxiety and fear to go in the MRI machine اللي هم بنسميها claustrophobia. اوكي. هلا اذا بدكم تعرفوا معلومه زياده، الاورثوبيديك implanted metallic devices يعني البليتس والنيلز والسكروز والوايرز اللي بنحطهم بالمرضى وحتى joint replacements النيز والhips والshoulders, they are not a cause of contraindications for the MRI. They are non-ferromagnetic devices. احنا الامبلانتس والماتيريالز اللي بنستعملها بالاورثوبيديك surgery mostly from 1990 and coming forward to this year كلياتهم non-ferromagnetic material. عشان هيك المريض اللي بحط plate, screw, they have hip or joint replacement, they can go MRI safely. The effect of MRI over metals that are ferromagnetic ممكن يعمل عندي heat effect وممكن يعمل عندي motion effect. المرضى اللي في عندهم sharp nails اللي هي شظايا، المرضى اللي عندهم bullet injuries، المرضى اللي عندهم foreign body with metals implanted inside their body، الMRI فيهم most likely they are contraindicated especially if they are near to a vital structure. بس بدنا نعرف هاي المعلومة إنه كل الامبلانتس that we are using in orthopedic surgery most they are MRI compatible. اوكي. طيب نيجي هنا في عندنا example شغلة بسيطة ومهمة بهمني دائما بالMRI وبالإكس رايز always to know how to count. عندنا مثلا on the left this MRI, this is to start with this part, this is C2, so this is 3, this is 4, this is 5, and this is 6. So this is 5, 6 cervical spine disc herniation. The X-ray is usually not diagnostic as in this picture. but we can see a decrease in the disc space, most likely related to degenerative disc disease rather than disc herniation. Degenerative disc disease is a separate entity which is different than the disc herniation. طيب, this is another MRI, the same, وعاملين عليها marking level of the vertebra. This is a C6, C7 disc herniation. Whatever the disc location is, posterior, posterolateral, or lateral in the cervical spine, a nerve root that will be compressed as C7, اللي هو the lower nerve root. Okay? The treatment in general is simplified in aptly textbook as rest, reduce, and remove. Okay? بدنا نعرف شغله, reduction, this is a very big mistake and no one believes in reduction. Because if you reduce the hernia, it will herniate back. Okay? You did not treat the cause. زي الانguinal hernia. When you reduce it, after the patient cough or strain, it will bulge back. The same is in the intervertebral disc. When you reduce the disc space, when you reduce the disc herniation, في multiple methods of reduction. أبسط شيء أو الميديكال used اللي هو we use sometimes traction table device. بنحط المريض على certain table that do traction to his lower limbs to increase the interdiscal space in the intervertebral disc that becomes uncompressed and spontaneous reduction of the disc back to the inside. But after you finish this maneuver or this treatment, the patient will go back to his life, they will strain, they will cough, they will have the same routine lifestyle, and the disc will herniate back. Okay? عشان هيك ما في شيء اسمه reduction of the intervertebral disc. في certain cultural methods بيستعملوها بعض الناس to do reduction of the disc space by hammering or by traction or by hanging the patient upside down. في multiple methods, all they are failures and should not be done. فسيمبلي صف الموضوع عندنا conservative management versus operative management. The conservative management is successful in almost 90 to 95% of the patients, which is simple, a brief period of rest, and then to ask the patient to resume his daily activities in a gradual manner, in addition to certain medications. The medications used in the conservative management, most likely they are analgesic and nerve cell stabilizers. The analgesics اللي بنستعملهم usually هم simple analgesics as the paracetamol, رقم واحد. Second, non-steroidal, either selective or non-selective NSAIDs. Opioids as for short-term relief of symptoms and never as a chronic therapy. Sometimes we use local non-steroidals to help and aid in the management of the symptoms. The muscle relaxants, they have a controversy. The muscle relaxants, when they are used alone, they don't have any improvement in pain relief. The muscle relaxants, when they are used in combination with NSAIDs, they have 30% more pain relief. So most of the time, when you use NSAIDs, when you use muscle relaxants, you have to combine them with NSAIDs to be effective. Okay? And other part of conservative management that are mostly used, which is nerve cell stabilizers, and most commonly used pregabalin and the gabapentin, and sometimes antidepressant as selective serotonin reuptake inhibitor can be used. Okay? Failure of conservative management is a relative indication for surgical intervention. Okay? The absolute indication to do surgery is progressive neurological deficit. دائما هذا المصطلح يمر معنا بأغلب الأشياء related to the spine. Whatever the condition, a progressive neurological deficit is indication for surgery. The second indication of surgery, which is coda equina syndrome. Okay? And in the cervical spine, myelopathic pain is an indication for surgery. Okay? Fine. Lumbar disc prolapse, we just summarize this disruption of the annulus, stretching of the PLL, it will cause acute back pain. This is the constellation of the symptoms. Tear in the annulus or tear, stretching of the PLL will cause the pain. Irritation of the nerve root, it will cause sciatica in the lower lumbar spine, or radiculopathic pain, which is called brachyalgia in the cervical spine. The pressure on the nerve root itself, it will cause paresthesia and numbness in dermatomal distribution and weakness in the muscles supplied by that nerve root. Okay? Compression of the coda equina, it will cause the coda equina syndrome that presents with urinary retention, and after that, loss of continence, loss of the sensation over the sacrum and the perineal area, Some patients, they present with something that we call sciatic scoliosis because of the certain position that the patient attained to decrease the nerve root irritation, and they will have limitation of back movement, ache, and sciatica. They are aggravated by coughing or sneezing. This is a certain position that this is what we call sciatic scoliosis. The examination, we start simply with the well-known test, which is called straight leg raising test in the lumbar disc herniation. The raising of the leg, which is normally have to be up to 70 degrees. Pain that starts with less than 70 degrees, the pain must be in the pain that must be in the gluteal region or in the back. Pain in the calf region, most likely related to poor muscle fitness. But when you do straight leg raising, the pain must be between mostly 30 degrees and 70 degrees, and the pain must be at that in the position of the gluteal region or in the gluteal region radiating to the back, or the pain directly in the back. Okay? Sometimes raising the unaffected leg, it will cause acute sciatic tension on the painful side. The aim of this test is to do tensioning over the affected nerve root. When the nerve root is compressed by the disc herniation, and at the same time you do more tension to the nerve root by tensioning the sciatic nerve, when you do straight leg raising, patients, they will have more symptoms because the irritation will become more. To exaggerate this motion, we have other tests like doing dorsiflexion of the ankle. Dorsiflexion of the ankle is a separate test during the straight leg raising test. We call it Liesge test. Okay? And at the same time, if you compress at the popliteal fossa during straight leg raising, it's called the bowstringing test. All of those, the aim of performing these maneuvers is to increase the tensioning over the nerve root. The imaging study, we already said it before, so no need to summarize it again. We have here an example of disc herniation. Just will draw markings again. Almost always you have to identify your level. A simple memorizing method is just specify where is the last disc space. This is the last disc space, so this is L5 and this is S1. Okay? And here this is for sure L4. Here we having this disc space, which is bulging inside the canal. Here we can see this is a posterolateral disc space compressing the coda equina and the exiting nerve root over this side. This is right or left. We can never tell unless we have a marker which is right and which is left. So I draw my markers now. It can be right, it can be wrong. Okay? But always you must have specification of the marking and the dexterity, which is right and which is left, over your MRI. The differential diagnosis of back pain, it can vary from anything. It can vary from tumor, either benign or malignant. It can vary to inflammatory condition like ankylosing spondylitis. It can vary to any even infection of the disc space or spondylitis. The treatment, we said in the rest, patients will have more relaxed position in the lumbar spine disc herniation when they have their hips and knees flexed, and to use anti-inflammatory medication, as we said before. The other parts of conservative management reduction is not useful, as we said. Patients who fail the pharmacological conservative management, we can use them with steroid injection in the epidural space or selective steroid injection around the nerve root. Okay? This is what we call epidural injection. When do we use it? When we fail to achieve proper symptom control with the oral medications. The use of steroids as intramuscular or intravenous is not warranted because of the side effects and the complications of using systemic steroids. So whenever when you use steroids in disc herniation, it must be either epidural or selectively directed to the nerve root. Okay? And failure to achieve the conservative management is an indication for surgery, which is the relative indication. And also we said before, the absolute indication is progressive neurological deficit, myelopathic symptoms, which is progressive, or having coda equina syndrome. The coda equina syndrome, we should know that it's used to be an orthopedic emergency Emergency, it means it must be performed within 6 to 8 hours. Now it's called urgency. Urgency, it means that it can be performed within 24 to 48 hours. نعرف الفرق انه emergency you have to do faster medical intervention. Urgency, you have more time to do the surgical intervention. So that's why code equina is an orthopedic urgency, not emergency as it used to be believed. Okay? We come, the physiotherapy in the management of disc herniation is also directed to relief of symptoms, which is a part of the conservative management. The other part, which is connected to our presentation and webinar now, which is the canal stenosis. The canal stenosis is a different entity than the intervertebral disc. Okay? So the definition of canal stenosis, either in the cervical or the lumbar spine, it is narrowing of the spinal canal due to hypertrophy of the posterior disc margin and the facet joint. Also, it's common in people in congenital vertebral dysplasia. So, عشان بس نعرف شغله, the intervertebral disc herniation usually is a disease of the young. عكس ما الناس بتفكر انه الانترفيرتبرال disc herniation بصير مع الناس الكبار بالعمر in 50s and 60s. لا, الانترفيرتبرال disc herniation is a disease of the third and fourth decade. The third decade هم الناس عمرهم in 20s بالعشرينات, والfourth decade الناس عمرهم بالثلاثينات. هذول هم ال people at risk of having a intervertebral disc herniation disease. Canal stenosis having a two main entity, في عندنا congenital canal stenosis which is rare and uncommon وما راح نحكي عنها بشكل عام. Canal stenosis that occurs in older population, usually they are in the fifth and the sixth decade, بالخمسينات وبالاربعينات and higher age. Okay? عشان هيك الكبار بالعمر بيشكوا من back pain, بيشكوا من sciatica او بيشكوا من radiculopathic symptoms or myelopathic symptoms. Usually they have canal stenosis related disease rather than intervertebral disc disease. Okay? هلا الديفينيشن حكينا narrowing of the spinal canal حكيناها already. نيجي للnext slide نحكي عن cervical canal stenosis. Patients usually they have neck pain and brachialgia, but also complain of paresthesia and numbness and weakness in the arms and the legs. إذا كان canal stenosis in the lateral component, in the lateral recess, and compressing the nerve root. The other part of the canal stenosis in the cervical spine, they may compress the cord and cause myelopathic symptoms. Myelopathic symptoms in the cervical spine related to canal stenosis, usually those patients will have ataxic gait, they will have a slow gait, they will have weakness in the upper limb, of fine control in their hands. Okay? The examination if it was compressed, which is in the anterior part of the cervical spine, it will cause decreased sensation to pain and temperature. If the posterior column was compressed, you will have diminished vibration and position sense. لأنه the causative compressive effects in the canal stenosis, they are multiple. One of them is the intervertebral disc degenerative changes and the inflammation around it, bulging in the intervertebral disc, hypertrophy and enfolded ligamentum flavum is one of the most important compressive effects in the canal stenosis. The ligamentum flavum becomes degenerative, hypertrophied, and becomes enfolded to the inside of the canal. This is another additive compressive effect. عشان هيك ممكن يكون عندي posterior column becomes compressed. Most likely the physical findings حتكون عندي diminished vibration and position sense. إذا كان compressive effect from anterior to the spinal cord اللي هو intervertebral disc or the facet joint itself, hypertrophy and cyst formation around it, they may cause compression of the anterior part of the spinal cord اللي حيعطي عندي decrease in sensation to pain and temperature due to spinothalamic tract compression. Lumbar canal stenosis, presenting symptoms mainly in those patients, is spinal claudication. Spinal claudication, which is defined as aching and or numbness and paresthesia in the thighs, legs, or feet. The symptoms come on after standing or walking for 5 to 10 minutes and relieved by sitting or squatting with the spine somewhat flexed. هدول المرضى لازم نميزهم بشكل رئيسي عن الفاسكولار claudication. مرضى neurological claudication, they complain بشكي انه بصير عنده back pain or back pain radiating to the calf or the gluteal region after walking 5 to 10 minutes. The pain is relieved by sitting or by bending their back forward, okay? Or even by squatting. Sitting will bending forward, will squatting. aim تبعهم is to do flexion over your hip to decrease the tension over the sciatic nerve. Okay? كيف نميزهم عن الفاسكولار claudication؟ هذا الجدول it summarize everything. مرضى neurogenic claudication they have more back pain. الفاسكولار usually they have uncommonly to have back pain. الpain relief بالneurogenic claudication is relieved by sitting or flex posture or squatting, and the pain relief is slow and gradual. المرضى اللي عندهم vascular claudication is not related to position. The most important part in vascular claudication is to stop the exercise, because vascular claudication exercise, you stop the need and demand for blood, the symptoms will decrease almost immediately. Okay? The vascular claudication usually have a fixed distance of claudication. Like those patients will tell you, I walk for 5 or 10 blocks of buildings, and then I immediately have the claudication. They have a fixed distance for the claudication. The neurogenic is variable. The symptoms in neurogenic claudication is more painful when you go downhill. We all know that when you go downhill, you need less muscle contraction and less muscle blood supply. Patients with neurogenic claudication, when they go downhill, they have more symptoms. When they go uphill, they will have less symptoms. Neurogenic claudication having less symptoms during uphill because we will have a more flex postures of our spine when we go uphill. The vascular claudication, when they go uphill, they will have more pain because they need more muscle contraction and more blood supply. The most important and specific test to differentiate between neurogenic and vascular claudication is what we call the stationary bicycle test. اوكي stationary bicycle تعرفوا هالبايسكل اللي بتكون موجوده بالجيم او ممكن عندك بالبيت that you do training with the bicycle in a stationary position. Patients with neurogenic claudication usually will not have symptoms while practicing over the stationary bike because you will have a fixed posture of your spine during the stationary bike test. The vascular claudication, they will have symptoms because they will increase the demand for blood supply to their muscles. Okay? The examination and diagnosis, the neurological deficit in the lower limbs, it may be present. Check for upper limbs polyneuropathy. Nerve conduction studies and EMGs sometimes may be helpful to differentiate between peripheral neuropathic symptoms rather than nerve root compression or cord compression. If the symptoms are unilateral and asymmetrical, stenosis or intervertebral root canal stenosis, it may present. The imaging study اوكي قديش معنا كم دقيقة؟ ثواني وراح يطفي. طيب المانجمنت either conservative or operative. conservative نفس neurogenic and vascular claudication. الايمجينج ستاديز اخر شيء وصلنا له نكمل من عنده. اوكي or degenerative changes or even having degenerative spondylolisthesis. And also we can measure the spinal canal. This is an old method that used to be diagnostic for canal stenosis, that we take the measurement of the spinal canal that have been performed over X-ray or CT. راح تشوف انه مرات كاتبين ببعض الكتب انه CT is the golden standard for diagnosis of cervical or lumbar canal stenosis due to certain measurements. Thus, the more reliable information that we always take from MRI, because we see all the compressive elements inside the canal, either related to intervertebral disc or related to the ligamental flavum or fascicular disc degenerative changes and arthritis. The use of myograph, as we said before, is used when MRI is contraindicated. This we can see an example. نعمل شوي بالماركر عشان نشوف زي ما حكينا دائما. This is how to count. This is the last disc space, which is obvious. So this is L5S1. Here we can see in this picture, we see this is the termination of the cord, which is the coda equina. Here we can see the compressive element from the intervertebral disc. And this black structure with the arrow is the hypertrophied enfolded ligamental flavum that will cause the compression from posterior to the neurogenic elements. This X-ray is an example of an X-ray myelogram. X-ray myelogram is somehow similar to CT myelogram. You inject a dye inside the intrathecal space and then you look for disruption of this dye or filling defect. So here we can see over this AP view, here we can see on this view interruption of the dye, which is called filling defect, which is very obvious on the lateral view. Again, this is L5, this is S1, this is 4, this is 3. So we have a significant stenosis between L3, L4, and also we have L4, L5 stenosis with interruption of the dye. This X-ray is almost historical. Most of the time we will not do it because we have the facilities to do CT, myelogram. If it was in MRI, was already contraindicated to go on for CT myelogram. This is the previous definition to take certain dimensions over a CT scan before with the parameters and dimensions of the canal. The treatment in canal stenosis is almost similar in terms of conservative. Most of the patients can be managed conservatively, with the conservative management being the pharmacological medication. If they don't for the injectable steroids inside the intrathecal space or around the nerve root, or to go for operative decompression. The surgical management that we use in this herniation is called discectomy or micro discectomy. Discectomy, it means that you take out the disc material that is protruding. Okay, microdiscectomy is different. That you use surgical microscope to do the surgery. The surgical microscope, it facilitates performing the surgery with smaller incision. Okay, which is the major difference than discectomy rather than microdiscectomy. In canal stenosis, you have to do full laminate the lamina and to take all the decompress all the compressive elements, starting from the ligamental flavum and the intervertebral disc, in addition to instrumentation of the spine. What we mean by instrumentation of the spine to fuse those segments, not to end up with intervertebral instability. Okay, that was simply intervertebral disc herniation. Now we will continue with the next topic, which is spondylolysis. اوكي هلا بحاول اعدل الصوت واظبط الامور. هلا هيك عبد الله الصوت عندي واضح، كل شيء تمام؟ طيب
دكتور ممكن سؤال؟
اوكي تفضلي.
عشان بدي اسال عن البوست لامينكتومي سيندروم، انه بعد ما بيعملوا عمليه اللامينكتومي لما بيصير فايبروسيس، انه في لها تصحيح سيرجيكال بعد ما مش بصير في.
هلا البوست لامينكتومي syndrome he is not typically a syndrome, he's related to adhesions and fibrosis. Okay, هلا after laminectomy certain patients at risk. هلا during surgery, initial surgery, sometimes we take certain precautions. We put adhesive barriers not to end up with the adhesions around the cord or around the nerve root or the coda equina. Okay, but if it occurs, we do revision and we take out all of the adhesions and we stabilize the spine, because one of the causative factors, which is microinstability and motion between the intervertebral segment, that will cause for more adhesions. So is there correction for this? Yes, for sure. We do revision and we take out all of the adhesions and we insert some material that we call adhesive barriers. Okay, the biochemical adhesive barriers is used for that circumstances in specific. مرات بنستعملهم بالprimary surgery, but most of the time we use them in revision surgery because they are more expensive a little bit.
اوكي شكرا دكتور، لانه الاغلب الناس يعني بيخافوا يعملوا العمليه، انه بيحكوا انه بعد ما بنعمل العمليه بتصير الامور اسوء من انه بدون ما يعملوها.
هلا المشكله انه اغلب الناس specifically بالكلتشر تبعنا usually they are not happy with the results. Okay, patients in our community, our culture, they need 100% results. هلا بعد surgery if was done properly with the proper indication, they will have an excellent results. المشكلة بالabuse of surgical management in patients who can be treated conservatively. So most of the patients will end up with then they are not happy. فهي المشكلة بالinitial indication Second of all, the proper management and proper surgery. اوكي
اوكي شكرا.
كثير من المرضى بالكلتشر تبعنا بحكي لك انه احنا عملنا باك سيرجري، عملت انترفيرتبرال ديسك هرنيشن، I'm not happy. المشكله بالكلتشر تبعنا انه عندهم اي باك سيرجري از ريليتد بالكلتشر والكومن لانجوج تبعنا انه ديسك هرنيشن. اوكي بس لا، احنا في عندنا completely different entity زي ما حكينا هلا. canal stenosis which is performed in patients who are 60s or 70s or even 50s. رح نعمل complete decompression of the lamina. We take out the disc itself. We insert a bony material between an intervertebral disc that we call it cages. We instrument the spine and we fix it with the screws, which is totally different عن شاب عمره 20 سنة عمل microdiscectomy, which is a quick procedure within 1 hour. The outcome in the people tongue is completely different than the international studies. The international studies is specifically directed to certain pathology وبتعطي certain good results or bad results in specific surgery. The people tongue in our community and culture in general they are not happy. ليش؟ لأنه أول شيء non-proper understanding for the patients. ناس المريض مش فاهم إنه أنا عمري 70 سنة، مشكلتي مش disc space herniation. مشكلته is much more bigger than having a simple intervertebral disc herniation. اوكي هذا هو الكونسبت من الموضوع. على البوست لامينكتومي syndrome اللي هي simply you have adhesions and recurrence of symptoms. It can be revised. You can take out all of the adhesive elements. You put certain material that we call it adhesive barriers, and mostly the patients are happy.
شكرا دكتور، يعطيك العافية.
طيب نرجع مرة ثانية شير سكرين نكمل موضوعنا عن spondylolysis و spondylolisthesis. طيب أول شيء spondylolysis نعرف إنه this is a big subject which is defined as a defect or an undisplaced stress fracture in the pars interarticularis of the vertebral arch without forward displacement. تذكروا بالمحاضرة قبلها حكينا عن spondylolisthesis is a forward slippage of the proximal segment in relation to the distal segment. عندنا هون spondylolysis is defined as an undisplaced stress fracture in the pars interarticularis. This is a very common issue in the pediatric age group, which is the most common cause of back pain in children up to the age of 18, as we know. Okay, the pars interarticularis, or it can be called the isthmus of the vertebra, is the portion between the neural arch that connects the lamina with the pedicle and the facet joint and the transverse process. هلا راح نشوف صورة ونحكي عنها. Okay, mostly the pars interarticularis defect بصير usually عندنا ب L5 vertebra. Okay, and it's more common in boys than in girls because that boys they participate more in sport activities rather than having genetic or hormonal factor. تمام؟ فبدنا نعرف ايش بالضبط هو البارز interarticularis. The pars is the junction between the superior articular facet and the inferior articular facet of the vertebra. And at the same time, it's the junction between the pedicle, which is almost here, and the lamina, which is almost there. Okay? This part is called pars interarticularis. Children who participate in sport activities that includes repetitive hyperextension exercise, just imagine this L4 and L3 above it, when they hyperextend back, you will have this part, which is the pars interarticularis, being compressed. So over here, the pars, when L4 and L3 having repetitive hyperextension exercise, the facet joints from above and the superior articular facet of the above vertebrae, it will hinge over the pars interarticularis, causing high stress over that part. Stress fracture of the pars interarticularis is called spondylolysis, which is the cause of the pain. Mechanical factors, they play the major role, especially when congenital abnormalities are present. Repeated extension, it will strain the lumbar spine, makes the pars interarticularis more susceptible for shear stresses. The pars becomes impinged from the inferior facet of the proximal, which is the cephal vertebra, which results in microfracture and attempts at repair. The presentation, children who are symptomatic, they are only 10%. 10% who approach or who comes in clinical practice. Okay, the other 90%, they may present at a later age group with what we call the isthmic spondylolisthesis. Okay, usually they come with low back pain aggravated by extension movement, as we all know in children. Okay, some discomfort may be elicited with deep pain percussion over the midline of the lumbar area. Full range of motion sometimes can be present with normal neurovascular examination. The most important test that we perform for those children is what we call the one-leg hyperextension test. We make those children to stand over one leg and to hyperextend their spine. When they perform this test, they will have pain in the back of in the lower part of their spine, plus minus radiculopathic pain if present. The imaging study that we perform to demonstrate pars interarticularis defect, to start with the X-ray. The AP and the lateral view are usually not helpful because of the overlapping shadows of the bone. So if we want to see the pars interarticularis per se, we perform an oblique view. If you can imagine it simply, you have to do a right and left oblique view to see the right pars or the left pars, okay? In appearance, we will have something that we call the Scotty dog. The Scotty dog, you can Google it and see the shape of this dog in specific. You can imagine it here over this X-ray with an oblique view, with here the eye demonstrating the pedicle, and here this one demonstrates the transverse process. Number 3, the superior articular facet. Number 6, the inferior articular facet. The most important thing, which is number 4, okay? Number 4, over here, it demonstrates that what we call the pars interarticularis. So this part, the neck of the Scotty dog, is the pars interarticularis. So having a Scotty dog over the X-ray, which is the normal, okay? What is pars interarticularis defect look like? We'll see the next couple of pictures. It's not present in the X-ray, but as we see here, this is a spondylolysis, which is seen over here. Over the X-ray, you will have an interruption of the Scotty dog neck. Okay, let's go back to continue together. We're going forward. Sorry. So this is the normal Scotty dog appearance. The imaging studies, we started with the X-ray. We see the Scotty dog. After that, the next favorable investigation which is CT scan. CT scan, it will demonstrate the interruption in the region of the pars interarticularis. MRI also is helpful when you have the pars interarticularis not completely fractured, but having bone marrow edema in the pars interarticularis, which what we call a pre-lytic defect. يعني إنه البارز لسه ما انكسرت, but it is impending to fracture. When it impends to fracture, بيكون في عندنا bone marrow edema in the pars interarticularis. هذه بنشوفها على MRI. Sometimes the X-ray is normal, CT is normal, the MRI is normal, but the patient, they are still complaining, specifically when they are professional athletes. في شباب صغار عمرهم 12 ل 18 سنة. They are professional athletes, they play with their clubs. Their general health is very important for them personally and for the club. هدول specifically بنعمل لهم شيء نسميه SPECT scan. SPECT scan, which is a single photon emission computerized tomography, which is a combination between bone scan that will show us if there is an increased metabolic activity in the area of the pars, combined with the CT scan to increase sensitivity and specificity to determine exactly where is this increased metabolic activity over the bone scan. The bone scan in orthopedic surgery that we use mostly, which is called technetium bone scan. Okay, so those patients who are positive on SPECT, definitely they have spondylolysis and they must be treated. Okay. The treatment, usually in the acute phase, we brace those children. We apply them specific types of braces that limits back extension and rest with pain medication. Okay. Surgery is rarely to be used in those patients. Specifically, those patients can go back to play after a period of 6 to 8 weeks and with gradual introduction back to the sport activities that they used to. And between 3 to 6 months after complete healing of the pars interarticularis, they can go back to participate in sport. الأهمية تبع spondylolysis, it's the most common cause of back pain in children. رقم 1. رقم 2, it's a predisposing to spondylolisthesis. اللي هلا رح نعرف ايش هي spondylolisthesis. اوكي. The spondylolisthesis زي ما حكينا بمحاضرة السباين تروما اللي هي الاكزامبل تبعها اللي هو الهاند بين fracture. It means forward translation of one segment of the spine upon another. The location is nearly always between L4 and L5 or L5S1. قبل شوي حكينا عن spondylolysis بتصير على L5 level. فال pattern of spondylolisthesis related to spondylolysis mostly it will be L5S1 زي ما هلا راح نحكي. بالspondylolisthesis, normal disc, lamina and facet, they constitute a locking mechanism that prevents each vertebra from moving forward on the one below. Forward shift or slippage occurs when this mechanism fails. هذا اللي حنحكي عنه بالdegenerative spondylolisthesis. الكلاسيفيكيشن اللي هو بنسميه Welts in human classification of spondylolisthesis اللي هو أول شيء عندنا ismic spondylolisthesis which is the most common اللي هو الاسمك related to spondylolysis. It constitutes almost 50%. Second اللي هو في عندنا degenerative which constitute 25%, and also dysplastic or pathological or post-traumatic or even post-operative. زي السؤال اللي سألتوني عنه post-laminectomy syndrome. Sometimes when we take out the lamina, you destabilize the spine, so it follows with spondylolisthesis, which is called post-operative due to more removal of the lamina and less locking mechanism between the vertebrae. Starting with the ismic spondylolisthesis, it typically presents in the teenage or early adulthood years. اللي هو ببلش عندنا as a spondylolysis. It may progress immediately to spondylolisthesis or it may present later on life. زي ما حكينا 10% من مرضى spondylolysis they present in clinical practice. The other 90% they present later in their 20s and 30s with back pain, diagnosis most likely related to ismic spondylolisthesis. The most common location هو usually L5S1. The etiology حكينا defect in the pars interarticularis in both sides is acquired due to repetitive microtrauma or congenital abnormality in the formation of vertebra itself that makes the pars more susceptible to injury as in elongation of the pars. The condition is more common than usual in those whose spines are subjected to extraordinary stresses as competitive gymnasts and weightlifters. هذول هم السبورتس بشكل عام فيهم repetitive hyperextension. الباليه dancers, dancers in general, الجيمناستيك athletes, weightlifters, هذول بشكل عام in their sport they have repeated hyperextension exercise. هاي الصورة شفنا قبل هيك حكينا عنها. This is the pars interarticularis defect. وزي ما احنا شايفين نحط شوي بعد إذنكم markers. This is L5 and this is S1. Okay? And this is a forward slippage of L5 over S1. Here we can see this part have been slipped forward. Okay? Which is related bilateral pars interarticularis defect. هاي عندنا axial view of vertebra. This is the junction between the pedicle and the lamina. Okay, so we see the lamina, and here this is the pedicle. This part, which is the pars interarticularis. Here we can see this defect in the pars interarticularis. This is not an acute defect. This is a chronic. ليش هذا chronic? Because of the sclerosis around the defect. This is a trial of healing and repair that apparently that have failed and did not occur. The pathophysiology of compression. The compression, it can lead to either foraminal stenosis, which is the main compressive element over the lateral recess stenosis, or sometimes central. احنا هنا بنحكي عن pattern of stenosis اللي بصير بالcentral part of the canal او بصير بالlateral recess او بصير بالforamina. السلايد اللي بعديها حنشوف صورة عشان نميز بينهم. المرضى اللي بيكون عندهم spondylolisthesis usually they have foraminal stenosis لأنه المشكلة عندهم هي بالpars interarticularis which is very close to the foraminal exit. Okay? The adult ismic spondylolisthesis at L5S1 often leads to radicular symptoms caused by compression of the exiting L5 nerve root in the L5S1 foramina. فبشكل عام عندي L5S1 مين حيكون فيهم compress؟ الupper part لأنه هون زي ما حكينا قبل حوالي ساعة بالintervertebral disc herniation الفار lateral disc بيضغط على النيرف روت اللي فوق. فعندي هنا L5S1 لأنه عندي بالاسمك spondylolisthesis أو بالadult spondylolisthesis الكompression جاي موجود بأي منطقة بالفورامينا. فعشان هيك صار زيه زي اللاترال disc herniation بالintervertebral disc بالlumbar region. Mostly those patients will present with symptoms of L5. الcompression ليش بصير؟ It can be due to hypertrophic fibrous repair tissue of the pars or spar formation of the posterior L5 body or bulge of the disc space of L5S1. Okay? Patients with lateral recess stenosis, it can be caused due to facet arthritis. Central stenosis is rare. إذا كان في عندي central stenosis, الcompression حيكون على lower nerve root اللي هو حيكون S1. Okay? هاي الصورة بتورجينا الستينوسز وين موجود بأي منطقة. نحط الماركر برضه عشان بس نوضح عليها. This is a central stenosis in the central part. This is the lateral stenosis. This is a foraminal which is outside. فأغلب المرضى هون حيصير عندهم الforaminal pattern or the lateral stenosis pattern rather than the central stenosis pattern. هنا another axial section بتورجينا patterns of stenosis. Degenerative spondylolisthesis is 25% زي ما حكينا, typically in middle-aged women. Middle-aged means in their 40s and their 50s. Okay? Location mostly this is different than the isthmic pattern. هذا بيكون عندي على L4, L5. The etiology is related to degenerative arthritis or sometimes related to crystal arthropathy in the facet and the disc with an intact lamina. Here بهاي degenerative spondylolisthesis ما بيكون في عندي pars interarticularis defect زي الموجود بالاسمك spondylolisthesis. هنا example of facet joint disease that will make the two vertebral level to lose the locking mechanism between each other. The pathophysiology, the forward slippage of the vertebral body here is mainly allowed by interdisc degenerative changes and facet joint degeneration. The disc degeneration leads to facet capsule degeneration and microinstability. المشكلة عندي هنا بالintervertebral disc, والمشكلة الثانية بالlocking mechanism between the facet joint. Arthritis, it will cause instability between the two vertebral segments and spondylolisthesis. Common sites اللي هو L4, L5. Central and lateral stenosis in the L4, L5, it will cause the descending L5 nerve root in the lateral recess to be compressed. يعني بالنهاية spondylolisthesis إذا أجلك أي سؤال أسهل شيء إنك تجاوب دائما L5 سواء بالديجنريتيف اللي هو فيها multiple factorials rather than the isthmic. بالنهاية حيكون عندي L5 اللي هو حيكون في compression لأنه حيكون عندي more بالديجنريتيف spondylolisthesis حيكون عندي central or lateral recess. الاسمك spondylolisthesis بكون في عندي foraminal. هذا هو الفرق بيناتهم إذا بدك تفهم الموضوع كثير منيح. هلا الforaminal stenosis that also may occur, it will also can compress L4. بس عشان سهل الموضوع على حالك بشكل عام, L5 is the most commonly to be compressed regardless of the etiology, either isthmic or degenerative. With dysplastic spondylolisthesis اللي هو third subtype, there is an abnormality of the shape of S1. S1 upper vertebral endoplate is concave. In the dysplastic spondylolisthesis, the upper vertebral of S1 is convex in shape that will lead L5 to slip over S1. Okay? The displacement is usually severe and it occurs slowly, usually associated with other neurological abnormalities. The clinical presentation in those children usually is failure to achieve milestones. Milestones in children, كلنا بنعرف children usually normal milestone تبعهم they sit between the age of 4 to 6 months. They achieve neck control between 2 to 3 months. They achieve urinary continence around the age of 2 to 3. Failure, they walk at around the age of 1. Failure of achieving those milestones, one of their differential diagnoses is to have a dysplastic spondylolisthesis. Okay? On physical examination, in general, the lumbar spine may be flat or hyperlordotic. They will have flat buttocks with a more vertical sacrum. They will have spastic gait due to hamstring tightness. Movement in the spine is stiff in those patients also. And sometimes in severe pattern, you also can feel a step-off deformity, but this is with the very severe pattern. This is an example of palpation of a step in severe cases of spondylolisthesis. And this is an example of having a hyperlordotic position of the spine. This is the classification that we used before in the starting of this lecture, which is called Wilson-Newman classification regarding the etiology, the congenital, the isthmic, the degenerative, and type 4 traumatic or pathologic or iatrogenic. And here's another important classification that you must be familiar with, which is called the Merding classification. The Merding classification is subclassified to 5 subtypes according to the slip percentage. Grade 1 up to 25%, grade 2 up to 50%, grade 3 up to 75%, and grade 4 up to 99%, and grade 5 is 100%. Grade 5 is called spondylolisthesis. راح نشوف هلا صورة عنهم نعلق عليهم. وهنا نحسب قديش الجريد of slippage. For example, in this image, we just subdivide the vertebra into 4 quadrants, and accordingly we manage the degree. بالصورة ناخذ صورة مثلا grade 2 هنا بنشوف إنه في عنا this is the slippage between L5 S1. We take the measurement X, which is here, and subdivided of the measurement Y, which is the total distance. ومنها بنطلع قديش the proportion of the slippage. Okay? فبهاي الطريقة بنقدر نعرف إنه this is grade 1 أو 2 أو 3 أو 4. نعرف شغلة إنه grade 1 and 2 on Nerding classification, they are usually called stable slips. Stable slips that they usually don't progress to more severe slippage. Grade 3 and grade 4, they are severe slips. Severe slips, they are unstable and they progress. فبالمانجمنت رح نعرف إنه stage 3 or 4, they are unstable slips, then always need surgery. Imaging, we start with the X-ray AP and the lateral and the oblique view. The oblique view is helpful for isthmic spondylolisthesis to demonstrate pars interarticularis defect. The CT scan to demonstrate the bony pathology if present, and for pars interarticularis defect if present. MRI is to evaluate the impingement of the neural elements. Here we can see this is an example of an X-ray with spondylolisthesis. نحط الماركر في عنا هون طبعا always you have to know what is your level. This is S1 here, this is L5, and this is L4. So this is an L4, L5 slippage. Also we can see, even this is a lateral view, we can see here there is a lytic defect which is more obvious over here. Okay, so this is an L4, L5 isthmic spondylolisthesis. مع انه احنا حكينا L5 S1 هي most common, but still L4, L5 isthmic spondylolisthesis may present. هنا other example of mild or grade 1 spondylolisthesis. في عندي minimal slippage in this area between L5 and S1. With here we can demonstrate pars interarticularis defect, which is big. لأنه احنا usually we need an oblique view to see it properly, بس هون كتير واضحة. On other diagram that shows the locations of the stenosis, it can be in the central part, as in here, or it can be in the lateral recess, as over there, or it can be at the exit part of the foramina. هذا اللي احنا كنا نسميها central stenosis أو lateral recess أو foraminal stenosis. هون نفس الشيء بنشوف عندنا a combination between central and lateral stenosis, but the foramina is still intact. هاي MRI to start with. This is a sagittal view at the level of the exiting foramina. بهنا نعرف شغله بالnormal anatomy. This is what we call the keyhole. Keyhole زي المفتاح تبع الباب اللي بتحط فيه المفتاح. Okay, فتحة المفتاح الباب. We here see asymmetry and compression of this element, and almost here the keyhole is totally obliterated. نشيلها مرة ثانية نحاول نتفرج. Now this is a normal keyhole. This is almost a normal narrowed keyhole. The keyhole is here normal. We see the lower part of the 3 vertebrae. The keyhole are completely compressed. هذه اللي بنسميها foraminal stenosis. كيف نشخصها؟ The treatment, the spondylolisthesis, is this. أول شيء we start with conservative management, which is suitable for most of the patients. So conservative management بكل spine disorder is usually the same. NSAIDs, pain management, physiotherapy to control the pain, sometimes muscle relaxants to achieve more pain relief, and nerve cell stabilizers if patients they present with radiculopathic symptoms. Patients who fail to achieve proper pain management over conservative management, and patients who have progressive neurological deficit, they are indications for surgery. هذه الجملة راح تنعاد بكل topics about the spine. Grade 3 or grade 4 spondylolisthesis, they are unstable, they need surgery. Okay? In operative management, the main goal is to stabilize the segment of the listhesis or to decompress any neural elements that is compressed. For children, usually we try with conservative management first, but those who have unstable slips, they need also surgery. هلا details of surgery مش مطلوب تعرفوها بشكل عام بالundergraduate level. This is an example of what we call short segment fusion. الصورة هيك ما تاخذ simplified. Here we have the screws in the intervertebral, in the pedicles of the vertebrae. We insert rods to achieve stability of 1, 2, 3 vertebrae, and we insert bone graft. The bone graft, eventually, those 3 vertebrae will fuse to achieve a one single segment that is stable without micromotion or instability for more that will prevent compression of the neural elements of the nerve roots or the canal. And thank you. This is all. مين شباب في عنده أي سؤال أو أي استفسار بشكل عام على الموضوع؟ احنا حكيناه بشكل مختصر. مين معي بعده؟
يعطيك العافية دكتور.
أنا عبد الله.
دكتور عادي أسأل سؤال عن موضوع ثاني؟
يس خذ راحتك.
دكتور بس الاناتوميكال ريدكشن أنا مش فاهم إيش هو يعني؟ إيش بيفرق عن فانكشنال ريدكشن؟
الاناتوميكال ريدكشن عن الفانكشنال ريدكشن، عن إيش بتسأل أنت؟ بالتروما إتسلف إن جنرال صح؟
إن جنرال. في الانترا ارتيكولار هم بيحكوها الاناتوميكال ريدكشن.
بس ذكرني شو اسمك هلا؟ أنت مضر صح؟
مضر نعم.
طيب مضر، شوف يا صديقي، هلا احنا بدنا نقرا اول شيء اسمه AO Principles in Fracture Management. AO Principles بقسم الكسور حسب الاناتوميكال بوزيشن، يعني ممكن الكسر يكون عندي epiphyseal او ميتافيزيال او diaphyseal. اللوكيشن تخيل انه انت بتحكي عن تيبيا انه عندك epiphyseal يعني انترا ارتيكولار. الرول بالاي او عشان بس ما تستغرب هي the biggest society of fracture management، زي لما تيجي تحكي الامريكان كارديك اسوشيشن، هدول هم اللي بيحطوا الجايد لاينز. بالاورثوبيديك تروما احنا عندنا الاي او هم اللي بيحطوا الاناتوميك، بيحطوا الجايد لاينز. الجايد لاينز انه انا بدي اناتوميكال ريدكشن بالابيفيزيال فراكشر، لانه this is a joint, this is an intra-articular fracture to prevent complication، انه يصير عندي osteoarthritis او or damage to the cartilage. You must achieve anatomical reduction، يعني بالعربي ترجع العظمه زي ما الله خلقها، زي ما كانت in its normal anatomy. functional reduction لو بنحكي الكسر بالتيبيا in the diaphysis. diaphysis في certain degrees of acceptance of reduction in all of our bones. بديش اخذ الديافيسيس تبع التيبيا، بدي اخذ الكاربال سوري، ناخذ الفيرست والسكند والثيرد والفورث ميتكاربال. بالميتكاربال بون in your hand you can accept a variation between 20 degrees of angulation up to 50 degrees. يعني الفيفث finger we can accept up to 40 to 50 degrees of angulation. هذا بنسميه ايش؟ functional reduction. معنى functional ما راح ياثر على الفانكشن of your hand and your life. اوكي؟ طبعا بين قوسين regarding your occupation، يعني انت functional reduction بالنسبه لموظف عادي بيفرق عن functional reduction لواحد بيعزف بيانو. اوكي؟ بس in general 40-50 degrees angulation in the fifth metacarpal bone in your hand is accepted. In the second metacarpal bone you can accept functionally up to 20 degrees. بس اذا بنفس الميتاكاربال بون بنحكي عن intra articular fracture you need anatomical reduction. هذا هو الفرق، انه لازم تعمل anatomical reduction ب certain areas we accept functional reduction in different areas. usually احنا امتى بدنا anatomical reduction؟ بالintra articular fracture اللي هم epiphyseal fracture. امتى بنقبل functional reduction؟ metaphyseal or diaphyseal fractures.
شكرا دكتور.
هلا يا مضر. مين كمان عنده سؤال؟ قديش معنا وقت بعدنا؟ ضل دقيقتين. حدا ثاني عنده سؤال بشكل عام؟ طيب شباب بس بدي اوصيكم على شغله صغيره لو سمحتوا. في كتاب اسمه Aptly Concise of Orthopedic. Aptly Concise يفترض شيء 200-300 صفحه. هو المرجع الرئيسي تبعكم. المحاضرات بتساعد تفهم الموضوع، بتساعدنا نشرح الموضوع بشكل عام، بس عشان نجمع الموضوع بشكل كامل اقرأوا كتاب اللي هو اسمه Aptly Concise. هذا هو recommended textbook، بتلاقوه soft copy او hard copy، بتقدروا تحصلوه. hard copy هلا كثير صعب تحصلوا شيء، بس مبدئيا soft copy easily بتقدروا تحصلوه كلياتكم. وبس هذا هو الموضوع، وجود لك ان شاء الله، والله يعطيكم العافيه. واذا في عندكم اي استفسار حتى بعد المحاضره تقدروا تبعثوا لي على الفيسبوك او على الايميل او على الجروب، اذا بتحبوا ان بابليك او ان برايفت براحتكم، ما عندي اي مشكله. يعطيكم العافيه وهاف ا نايس داي. باي باي. الله يعافيك.